Hi, everyone. Thanks so much for joining us today. My name is Hope Avalone, and I'm the Senior Manager of Patient Education here at the Lymphoma Research Foundation. It's my great pleasure to welcome you to our webinar, Update on Follicular Lymphoma. During today's webinar, you'll hear from two expert speakers, and you'll have an opportunity to ask questions. You can ask those at any time using the Q&A box at the bottom of your screen. Any questions you submit through the Q&A box can be made anonymous, and we will take as many questions as we can following the presentations today. As a reminder, this webinar is being recorded. At the end of the program, you'll also be prompted to complete a program evaluation, and we do ask that you complete the brief survey because we value your feedback and we aim to incorporate it into future programming. And before we get into the presentations, I'd like to share with you a few brief words about our organization. The Lymphoma Research Foundation is the largest nonprofit organization that focuses specifically on lymphoma and chronic lymphocytic leukemia. Our mission is to realize the promise of science to, of course, eradicate lymphoma and serve the community touched by this disease. All of our work is led by our Scientific Advisory Board, which is a group of 45 leading lymphoma experts from around the country. And in addition to today's program, the Foundation has many other programs and services available for you. We offer both in-person and virtual programs so that you can continue your learning throughout the year. We have our menu of programs here, and you can learn more and register for any of them at lymphoma.org/programs. But I did want to specifically highlight our upcoming Living with Lymphoma program, which will be held on Saturday, November 8th. And Living with Lymphoma is an opportunity for patients to learn more about their specific diagnosis, as well as a variety of supportive care topics. So the agenda for this program includes subtype breakout sessions, including one on follicular lymphoma, as well as sessions on integrative oncology, coping during active surveillance, sexual health and intimacy, and long-term side effects. So if you'd like to view the full agenda and register, you can visit lymphoma.org/livingwithlymphoma. In addition to our programming, the Foundation offers a wide range of support services. Our helpline has master's level trained staff who can provide individualized information on all types of lymphoma, as well as on treatment options, clinical trial navigation, and connections to resources such as financial assistance. We also offer a peer support program called the Lymphoma Support Network. And through the Lymphoma Support Network, we can connect patients and care partners with others who have been through similar experiences for emotional support and encouragement. The Foundation also offers comprehensive disease guides and fact sheets, which can be ordered or downloaded for free on our website. Again, that's lymphoma.org. And please also look for us on YouTube, where we spotlight different subtypes and treatment options. I'd briefly like to take a moment to thank our program supporters. Thanks to their generosity, we're able to host programs like today's webinar. For now, we have a wonderful program planned for you today. You'll hear from two expert speakers, Dr. Philippe Armand of Dana-Farber Cancer Institute and Dr. Carla Casulo of the University of Rochester Wilmot Cancer Institute. I'm first honored to introduce our first speaker, Dr. Philippe Armand. Dr. Armand is a hematologist oncologist at Dana-Farber Cancer Institute, where he's the chief of the Division of Lymphoma and the Harold and Virginia Lash Endowed Chair in Lymphoma Research. He's also a professor of medicine at Harvard Medical School, and we are thrilled to have him back this year for our program. So thank you so much, Dr. Armand. I'll now turn the talk over to you.
Thank you so much, Hope. I'm delighted to be here again this year. And for those of you who were with us last year, this will be an update. A lot of the material will be similar, but Hope made me promise to not say the same jokes. So I'm going to start to share my slides. How's that? Good?
Yep, looks good.
Perfect. Thank you. So this is an update on newly diagnosed follicular lymphoma. Dr. Kosulo will take us through the considerations for relapse refractory disease. And again, a very quick introduction to the world of lymphoma, which is very complicated. We're pushing towards 100 different kinds of lymphoma. I don't think any of us, even lymphoma specialists, can keep track. But one way to think about it is to separate lymphoma at the top into non-Hodgkin and Hodgkin lymphoma. So we're in the world of non-Hodgkin lymphoma. And within that, there are lymphomas that can arise from B cells or T cells, which are two different types of lymphocytes or white blood cells. So we're in the B cell non-Hodgkin lymphoma world. And within that, the most important distinction is how aggressively the lymphoma behaves. So they're what we call the indolent or slow-growing lymphomas and aggressive lymphomas. And follicular lymphoma is an indolent B cell non-Hodgkin lymphoma. So that's where FL lives. There's something very important, which is the concept of histologic transformation. And that happens when follicular lymphoma transforms into a more aggressive lymphoma, typically something called diffuse large B-cell lymphoma. That's a very important topic in FL, but it's not one that I'm going to cover today. So a lot of how we approach FL is informed by its natural history. And the first thing that people hear or read about follicular lymphoma is that it's incurable. I think we have to be very careful about this incurability concept. First, I personally don't think it's true. I think there are people who are cured of follicular lymphoma, and we'll talk a little bit more about that later. But it's a good place to start to talk about watchful waiting, which we'll come to in a second. There are a lot of effective treatment options for follicular lymphoma, and more coming all the time. So there are a number of approvals in the last few years just for this disease. Very long expected survival, and there is this risk of transformation, which I alluded to earlier. So let's start with watchful waiting, which is really a fundamental concept in follicular lymphoma, and which is different from how we approach typically aggressive B-cell lymphomas or T-cell lymphomas or Hodgkin lymphoma. It is more or less unique to indolent B-cell lymphomas and CLL. And this builds, as I mentioned before, on the idea of incurability. So the idea is, okay, a patient has follicular lymphoma, we have a lot of therapies, but our therapies, the goal is not to cure them. So if they feel completely fine, what's the benefit of treating them? We can only make them feel worse by administering treatments which have some side effect risk, as opposed to just watching and waiting for something to require treatment. So that's the idea behind watchful waiting. And they were older trials. This is like really old trials. We're talking maybe 30 years ago, comparing chemotherapy to watchful waiting. So randomizing patients to either get treatment or no treatment. Those are patients who wouldn't otherwise have needed treatment. And those trials showed no survival benefit to starting chemotherapy early. Probably the most important trial in this space is a trial that was done in the United Kingdom looking at rituximab. Rituximab is a very powerful drug in follicular lymphoma. It's also well tolerated. So it's a good drug to try and ask the same question. If we treat early, does it make a difference? And in the slides that I presented last year, if you look on the left is what's called progression-free survival. And because that will come up again, I'm going to try to define it quickly. Progression-free survival is the amount of time until relapse or death. Unfortunately, we rarely talk about death, but so that's the amount of time basically of a patient staying in remission. And if you look on the left, the patients who got Rituxan, which is the red curve, had much better progression-free survival, right? Which makes sense because a lot of the patients in blue who were on watchful waiting at some point would progress and need treatment. So that makes sense. But if you look on the right, there was no difference in overall survival. So starting Rituxan early had no benefit in terms of the ultimate outcome of the patients. Now what we have this year is we have the update on this trial. And the conclusion is the same, but the insights are interesting to me. So I'm going to take you through these three curves briefly. There's still no survival benefit, which is the curve at the right, the overall survival. And if you look here, so this trial had actually three arms. Some patients got watchful waiting. Some patients got Rituxan, just the 4 weekly doses and then stopped. And some patients had the 4 weekly doses and then maintenance with more Rituxan. So if you look at the curve, the light blue curve at the bottom, remember those are patients who got nothing. And after about 6 years, half of them still hadn't required treatment. So that tells you if you get diagnosed with follicular lymphoma and you're considering watchful waiting, in this population, the average time that they could do watchful waiting was over 5 years. In other studies, it's been a little shorter. It depends how you select patients, but that gives you an idea that people can wait for a long time. This is the middle panel is the time to second treatment, because that's what matters, right? If you start treatment early, if you don't start treatment early, does it matter when you need the second treatment? And you can see there was no difference, but also at 15 years, is where the red line is, more than 3/4 of patients had not required a second treatment beyond rituximab, which is also remarkable. And then the last thing is also to say that at 15 years, about 3/4 of patients were still alive. And remember, follicular lymphoma is not typically a disease of young people, so dying doesn't mean dying of lymphoma. Many of those patients will die of other causes. So what about quality of life on this study? What happens to the quality of life between watchful waiting and Rituxan? And overall, they were pretty similar. There were some benefits in that trial to starting Rituxan. It improved emotional well-being, feeling in control, coping with the diagnosis. I would argue it's a very complicated trade-off because in order to have this feeling in control or coping with diagnosis, it means coming in every 2 months, getting a therapy that has side effects, including in particular infection risk. And this has been much more heightened recently because of COVID, because rituximab increases the risk or the problems that people have with COVID. So there's a downside to doing it. So in general, for example, at our center, we tend not to recommend Rituxan for people who don't need therapy. We say, just wait. And this brings me to an important point, maybe the most important point of this whole talk, which is the importance of quality of life, right? So the watchful waiting is not about waiting. So I try to cross out that hourglass. It's not about waiting for something bad to happen. It's about patients living their life and living their life to the fullest. And if they're doing well, if they don't need treatment, and if we know we have treatment for when they need it, in some ways, that's ideal. And the goal is not to spend every day waiting for what's going to happen next. So some people call it active surveillance for that reason, which is nice because it means you're not just waiting. Okay, some other useful concepts for follicular lymphoma. One is the idea of trade-offs, because all the clinical trials, basically, there's been very few trials which showed a benefit in terms of overall survival. The one place where we're pretty sure that overall survival is better is if you use rituximab in frontline, for example. But now, basically, everybody gets some form of rituximab or an equivalent drug when they get treated in frontline. I put a little danger icon because it doesn't mean the other treatments don't help with survival. It just means the clinical trials don't show it because people can get a treatment later or other treatments later. So it's hard to capture that benefit in a clinical trial. But it doesn't mean that overall we haven't significantly improved survival in this disease. And then the trade-off is between three things in general: the toxicity of treatment, the efficacy, which is both the response rate, how many people respond to treatment, and how long do responses last, or the duration of treatment, and then the convenience for patients. And as of yet, meaning as of 2025, we have no personalized therapy. So there's no great way to take an individual and say, okay, this person needs X or Y treatment. For most patients, the trade-offs are similar, and we don't know really what patient would benefit from a particular treatment. So we tend to have similar conversations with all patients about what the trade-offs are. And the last thing is that the information is imperfect. So this makes it very hard to conduct clinical trials in frontline follicular lymphoma because measuring outcomes is hard. Survival outcome, which is something, of course, everybody cares about, overall survival, is very hard to change with a clinical trial for reasons we talked about. And the trade-offs that we talked about are hard to capture in a clinical trial. How do you measure convenience? How do you measure even the quality of life? We have questionnaires that we give to patients for quality of life, but they haven't been really hard endpoints of our clinical trials, though many of us would argue they should be. So now let's talk about actual options. I broke it down to early stage, advanced stage, and future stage. So in early stage, we often think about radiation. And the reason is radiation seems to be a cure for about half of the patients. I say in quote because probably many of these patients, if we did nothing, would not die of their disease. They would be on these long-term curves. So we're not sure. And certainly there's been no indication that radiation improves survival, but we often do it because the downside is small. And if we can get rid of the disease in and it never comes back, I think everybody feels better. For advanced stage, we talked about watchful waiting as an option. Also, radiation can be useful at lower doses for palliation. If there's a local site that's causing problems, for example, if somebody has a large lymph node in their armpit, let's say, that's causing discomfort, low-dose radiation can work very well for that. And the four major options today that are available not on the clinical trial are the follows. So as follow, we're going to go through each of them quickly, but note that that's where the trade-off is. So they vary in their toxicity, their efficacy, and their convenience. Probably the most commonly used is rituximab plus chemotherapy. There are different chemotherapy options. We at Dana-Farber, we tend to use bendamustine, but different centers have different preferences. But that's kind of that's sort of the benchmark, and it's very effective. The vast majority of patients will respond, and the average responses with Rituxan and chemotherapy, something like bendamustine, are probably in the 6-year range or so. So it's quite an effective treatment. A few years ago, there was a large trial that compared Rituxan and chemotherapy to this regimen, which is Rituxan and lenalidomide, or Revlimid. This is also called R² because Rituxan Revlimid. So lenalidomide is a pill, and that was very exciting because people thought, well, maybe we can treat Follicular lymphoma with a pill and an antibody as opposed to chemo. The bottom line is there was no real difference between Rituxan lenalidomide and Rituxan chemo, but because it's more treatment with lenalidomide, people have to be on it for a while. The pill does have toxicity. It wasn't FDA approved. So it hasn't really caught on. It's still some people who really want to avoid chemo. It's an option, but it hasn't certainly emerged as a winner, I would say, in this area. You can also use Rituxan by itself. That works pretty well. Probably about 3/4 of patients will respond. So it's pretty good. It's not fantastic. It's not as good as the two I just mentioned, but it's good. It's easy. Doesn't have a lot of side effects. It's also the one where the duration of response is going to be the least long. So it's an option, not a bad one, but it's not. It's used a little bit less probably because of those reasons. And then before we talk about this one, which is obinutuzumab, chemotherapy, and maintenance, I want to talk about the concept of maintenance for a second. So maintenance has a rich history in follicular lymphoma, and it refers to continuing a treatment at the end of induction. For example, with Rituxan chemotherapy, you do 6 months of treatment and then continue Rituxan typically for 2 years. And this was done in this study that I showed here, which was called the PRIMA trial that was done in Europe and published, as you can see, about 6 years ago. Actually, it was first published longer than that, but republished 6 years ago. And if you look at the curves again, now that you're more hopefully familiar with the outcome, the patients who got 2 years of Rituxan maintenance had a longer progression-free survival. So they went longer, this is on the red curve, they went longer before the disease progressed again. But if you look at the bottom, there was absolutely no difference in overall survival. So again, it's a trade-off. If you do maintenance, on average, people will stay in remission longer, but they won't live longer, and they have to come to the doctor every 2 months, get an intravenous or subcutaneous treatment, and there are those side effects of infection that we talked about. So again, different people do different things. We tend not to use it very much at Dana-Farber because we feel like it's not worth it in terms of infectious risk, et cetera, but it is an option. So back to this regimen, this is a combination with obinutuzumab, which is a newer type of rituximab. It's an antibody like Rituxan, but a little newer. And that combination was a little bit better than the same combination with Rituxan, but it's marginally better, no effect on overall survival, and it requires maintenance, which, as I just said, we typically are a little bit hesitant to use. So again, for us, we don't often use this regimen, but it's very acceptable to use it. So that gives you a sense, I hope, of the 4 major treatments and what one might think about in terms of choosing between them. The choice is built around the following, right? So you understand it's a multidimensional decision because you have to factor in all these different parts, and they're all different between the 4 different treatments. It depends a little bit on the burden of disease. So the more we worry about someone, the more likely we are to use chemotherapy. And then it depends on whether patients have symptoms, laboratory abnormalities, et cetera, and on what the goal of treatment is. So we talk a lot about this, what's the goal of treatment? I would argue that goal of treatment doesn't mean anything for me, really. Like, people just want to be well. It's more prioritizing between side effects, efficacy, and convenience. So, of course, the goal is to have no toxicity, long remission, and perfect convenience. But we can't do that yet. So we have to do a trade-off among them. Okay, so let's go from advanced stage to future stage, by which I mean, where are we going with this? Where's frontline therapy likely to go soon? It may be that as we do more scientific studies and more clinical studies, maybe we will learn to personalize therapy. Maybe we'll be able to look at a patient or patient's tumor or blood work and say, okay, this person is very likely to benefit from treatment X. That would be nice. And a lot of people working on this, ourselves included, but we're not quite there yet. It may be that we'll use targeted therapies like typically pill drugs that impact certain pathways in the cells. But I think most likely we will use more what's called immunotherapy. And there are a lot of different kinds of immunotherapy. The one that's becoming the hottest thing in follicular lymphoma is so-called bispecific antibodies. Dr. Kasula will talk more about bispecific antibodies. I just want to give you a flavor of what it's looking like in frontline treatment of lymphoma, because now we have a bunch of clinical trials that are looking at bispecific antibodies in frontline, and the results are very encouraging. There was a trial that was done by Lorenzo Falchi in New York at Memorial of just mosunetuzumab by itself. So there's a bispecific antibody, again, in frontline treatment. And if you look here, OR, which means overall response, 95%, CR or complete response, 92%. And at 1 year, as you can see on this graph, about 90% of patients were still in remission. So that's a very good result, compares well with, let's say, chemotherapy, which makes this treatment exciting. There's another bispecific antibody called epcoritamab. It's also been tried in frontline with different partners. They all look very good, as you can see. The one at the bottom, I'll highlight because it's a trial that Dr. Casulo is doing with us, and it's just rituximab and epcoritamab. So no chemo, just an antibody and a bispecific antibody. And you can see the results are very preliminary, but response rate was 100%, complete response rate 92%. And at the time this was presented, no patient had progressed. Of course, nothing is 100%. And in fact, since that presentation, there's been one patient who's progressed on the trial. So we know that curve will drop, but it's just to say that these bispecific studies in frontline look very encouraging. And in fact, there are now 1, 2, 3, 4, 5 phase 3 studies. So studies that might lead to FDA approval that compare bispecific antibody in combinations or alone to our standard of care. Those will read out in the next few years. That is likely to change the field fundamentally, because it's possible that some of these studies are going to be positive and show that bispecific are better than our current treatment frontline. Of course, it may not be. We have to wait for the results. But if they do, they will change probably how we treat patients in, let's say, the next 3 to 5 years. So in conclusion, I'd say the following. The first is that cure is a confusing goal. I go back to this idea, people say, oh, follicular lymphoma is incurable. That's confusing. So I've drawn a survival curve, a completely hypothetical survival curve between treatment A, treatment B, treatment C. And you can see on the x-axis is time, and on the y-axis is percentage of people who survive, right? There's no question that C looks better than B, B looks better than A in terms of survival. But if you get to the edge of that graph and you haven't died of follicular lymphoma, people do die, right? All of us do, all of us will, whether it's from heart disease or, whatever. And so all we need to do is keep the lymphoma at bay for longer than the natural life expectancy of the patient. And for something like treatment C, that's going to happen for most patients. So in a way, this is what we call a functional cure. It doesn't matter so much whether we really cure patients or whether we keep people well until the end of their natural life. And if that requires 2 treatments instead of 1, the treatments are tolerable, it's not the end of the world. What matters is that we control the disease. To me, that's more important than curing the disease. The other thing is there's a lot of talk about chemo-free in follicular lymphoma, which is nice. Chemotherapy does have side effects, but chemotherapy is very effective. And I would argue it serves a purpose now. The goal of our treatment is not to get rid of chemotherapy. It's to find the best treatment. If the best treatment includes chemotherapy, then it's chemotherapy. It's not the chemotherapy now. We're good enough about giving it that people do fine with chemotherapy. So that's my second point. And then the third and fourth one is trade-offs are likely to always remain relevant in follicular lymphoma and paramount. I think it's not likely that we're going to find a treatment that's easy, convenient, and cures 100% of patients. Until we have that, we're going to have to deal with trade-offs. And this, I think, is what's going to shape and what should shape the future of clinical trials in follicular lymphoma, because we have to be able to capture those trade-offs, and means we have to care about the trade-offs. We have to care about convenience. We have to care about quality of life. We have to care about how patients feel on a certain regimen, be able to capture that, analyze that, compare that, et cetera. It's much harder to do than it is to say, but in the community of follicular lymphoma research, there's a lot of interest now in doing that. And then the last point that I would like to leave you with is that optimism should prevail. In 2025, we have a lot of good treatments. There's very exciting stuff on the horizon, and most people with follicular lymphoma should be able to do well for a very long period of time. Of course, we hope to do better, but I think there's no reason not to be optimistic today. And with that, I will stop and thank you very much for your attention.
Thank you so much, Dr. Armand, for kicking us off today and for ending on a note of optimism. I'm now thrilled to introduce our next speaker, Dr. Carla Casulo. Dr. Casulo is a hematologist oncologist at the University of Rochester Wilmot Cancer Institute, where she is also a associate professor of medicine and the assistant director of cancer research training and education. And Dr. Casulo is also a former scholar under the Lymphoma Research Foundation Scientific Research Mentoring Program. And we're again so happy to have her back for today's program. So thank you, Dr. Casulo, and I'll now turn the talk over to you.
Thank you so much, Hope, and to the Lymphoma Research Foundation for the invitation. I always love coming and giving talks and getting great questions. I've been manning the Q&A, and there's some phenomenal questions that are being asked. So we look forward to answering those questions. So I'm going to share my screen, and hopefully everything looks okay to you. Can you see everything okay?
Yeah,
Perfect.
looks good.
All right, great. So thank you to Dr. Armand for a great presentation to start us off. And a lot of the things that he discussed, I will be recapitulating a little bit and give you a little bit of a philosophical framework for how we approach relapsed and refractory follicular lymphoma. And I view follicular lymphoma as one of the most interesting forms of lymphoma to treat for many reasons. I too find incredible hope in follicular lymphoma. It's a very exciting time to treat patients. We have so many new and wonderful treatments available, and I think that things are only getting better. So I view things very optimistically. So I'm going to focus on treatment options for patients with relapsed and refractory disease, and I'm going to talk about what that exactly means. So having relapsed lymphoma refers to a condition where lymphoma comes back after it's been successfully treated, and it implies that there's been a period of remission. So no evidence of lymphoma on scans or on tests to the best extent possible. Typically, this is after some form of treatment has been initiated. Um, Progression of lymphoma could happen if someone started watching weight, like Dr. Armand already discussed, and then we see that lymphoma grow. So that's called progression. But relapse implies that the lymphoma has gone into remission and has returned. Having refractory disease is a scenario where the lymphoma doesn't respond at all to treatment. Fortunately, that doesn't happen as often, but having relapsed or refractory lymphoma is, while very distressing, it doesn't necessarily mean that there isn't a hope for retreatment or that you can't be successfully put into remission again. So lymphoma can become relapsed or refractory if there are cells left in your body after treatment is complete. And because this follicular lymphoma grows slowly, if you can think about an analogy of like a fire, like a forest fire, and then it gets put out, but there's tiny little glowing embers that don't mount up to a fire, but that are just kind of right below the surface of detection. And those cells, if you think about lymphoma that way, those cells, those tiny little embers, could gradually build up and grow again. And there are sometimes small numbers of lymphoma cells in the body that cannot be detected on tests. I saw some people asking about how do you find it if your blood work looks normal? And the majority of the time, actually, your blood work will seem normal with follicular lymphoma, unless there's something that's really wreaking havoc in the body that kind of shows up on blood tests, and we don't necessarily want that. So having good blood tests is a good thing if you have lymphoma. But a relapse can happen if you've had a partial remission or if you've had a complete remission, which means no evidence of disease on your scans. Partial remission means that the treatment worked to an extent, but there's still some lymphoma cells left behind that are just hopefully just going to stay stable. So what are some treatment options for relapsed refractory lymphoma? Well, the good news is that not everybody actually requires treatment if their disease comes back. Similar to watchful waiting in the first line setting when someone's initially diagnosed, you can have watchful waiting at the time of follicular lymphoma recurrence as well, because not everybody needs to be treated when their lymphoma comes back. And the decision to treat someone depends on many different features. So number one, what was your prior treatment? Was it watch and wait, which is a form of an active decision of a treatment approach? Was it rituximab? Was it chemotherapy? And if so, was it bendamustine? Was it CHOP? Was it lenalidomide? And then what's the time from your last treatment? So we pay attention to the duration of time that someone spends in remission and how long it took for that lymphoma to come back. So time from your last treatment. What was the response? Did you have stable disease, meaning that the lymphoma just kind of stayed in a frozen state? Did it improve and it was a partial remission, or did it completely go away and that's a complete remission? And also, what's the health condition? Are you someone that is, suffering from active heart disease and you just got through getting a stent placed? Or are you dealing with a new diabetes diagnosis and you have to get your blood sugar under control? Or did you just, break a bone and that needs to heal? So there are lots of the situations that play a role into, is it safe, is it appropriate, and when is the best time? So in terms of prognosis, we know that number one, most patients with follicular lymphoma will have a very long life expectancy, but prognosis at the time of relapse is affected by many things. One of the things I mentioned is when that relapse occurs, if it occurs early or if it occurs late, and I'll kind of go into that a little bit. Is there transformation, as Dr. Armand discussed? Can it go from follicular lymphoma and then have that arch and become a more aggressive lymphoma known as diffuse large B-cell lymphoma? Is this the first time it relapses, or have multiple relapses occurred and now someone's on their fourth or fifth line treatment? So all of those features play an important role in us understanding what the prognosis of someone is when their lymphoma comes back. So what we know about relapsed follicular lymphoma is based on some work that fortunately the Lymphoma Research Foundation has helped me to execute in terms of understanding the importance of time to recurrence. So these curves are called Kaplan-Meier curves. Dr. Armand showed these already. This line here is survival in months, in percent, sorry, overall survival in terms of percentage. And on the bottom line here is years. So here at time zero, 100% survival, that's kind of the implication. And so we track these little like divots over time to see what survival looks like. So this is based on a study from my colleagues at Mayo Clinic that demonstrated that this top line here are patients that have the general population in the US and France. This is general population, meaning that at this particular time, most people will remain alive, 10 years later, that some people will pass away. And then this is the survival of patients that have early relapse of their follicular lymphoma. So you can see that when someone has early relapse, it happens within 2 years, their survival is actually unfortunately lower compared to the general population. However, if someone stays in remission, their survival is just the same as a general population. If they stay in remission at least a year or between a year and 2 years from their diagnosis, they have a very good survival. And then this is part of our work that showed similar findings, kind of pivoting to the opposite perspective, is that if someone does have that early progression, you can see that their survival is lower, unfortunately, compared to patients with follicular lymphoma that do not have an early disease event. And this is from many different reasons. One of them can be transformation. Sometimes there are lymphoma cells that become more aggressive, and then that can shorten someone's survival. The other reason, it could just be bad biology of the follicular lymphoma that kind of allows it to come back early. And so this is an area of worldwide investigation that we're focused on very heavily to understand what makes this happen and how we can prevent it from happening. But this is what we know about relapse. And then we also have learned that unfortunately, each time someone has relapse, the remission from that is shorter and shorter. And if it does become transformed, then that can also be a very serious illness. But again, I want to emphasize that even if those things happen, there's still a lot of hope and a lot of things that we can do to get patients back in remission and live a long life. So let's shift gears a little bit to talk about treatment approaches. And we talked a little bit earlier about the landscape is changing. There's a lot of new, very interesting things. But I wanted to take a step back and talk about what are the traditional treatments, the tried and true chemotherapies, the things that we've had going for the last 30, 40, 50 years. So we know that chemotherapy and radiation are very important basic treatments that have been here for decades, and they're extremely effective. However, as Dr. Armand mentioned, there's always a trade-off. Some of them have side effects. Sometimes they don't always cure. Sometimes we can still see relapse and refractory disease. And the way that chemotherapy works is that it gets right down to the cellular level. So if this is a cell here, and cancer cells compared to normal healthy cells have this feature that they divide more quickly, more rapidly. And so these are the rapidly dividing cells. And this little structure in the middle here is DNA. So DNA is the backbone of how cells divide, and it's what gives us our genetic material. And when a cell is growing and dividing, a cancer cell, like any other healthy cell, it grows faster. And then the objective of chemotherapy is to interrupt that DNA replication by either putting little jabs and little sticks in it, which is these alkylating agents that cross-link. So this cyclophosphamide is the ingredient in CHOP. And then doxorubicin is the H medicine in CHOP, for example. So this doesn't allow some of those key ingredients of the cell from being made. And then there are some other ones here that work in different ways, but the objective of chemotherapy is to interrupt the way that cells divide. One of the downsides is that the rapidly dividing cells happen to be cancer cells, but other rapidly dividing cells in our body are also subjected to injury, like our bone marrow, which is where all the cells are made, red cells, white cells, platelets, which is when we talk about having low blood counts, the GI tract, like your stomach, nausea, vomiting sometimes, diarrhea or constipation. It affects the lining of the GI tract, and then the hair, which is why hair falls out sometimes. So it can affect normal tissue. So that's always a trade-off. But what we've learned about traditional chemotherapy is that because of some of these features, we know that we can combine them with new treatments like immunotherapy, and it's an opportunity to study new approaches that target the cells more on the inside and in certain pathways that they need to grow. And it's an opportunity to study immunotherapy. So I'm going to talk about what that is next. So we combine chemotherapy with lots of other ingredients. So sometimes we can combine them with vaccines against cancer. We can combine them with adoptive T cell therapy, which is, I'll talk a little bit about that, with immune modulators, which includes lenalidomide, which we heard about, sometimes viruses, radiation, and then obviously chemotherapy, and then these checkpoint inhibitors and other immunotherapies. So these are things that we're actively learning how to combine with chemotherapy to kind of give it another line of attack and not just rely on the traditional ways that cells can die. So this is kind of a big overview of new treatments for relapsed and refractory follicular lymphoma. So this is kind of departing a little bit from the traditional chemo and looking more at targeted agents. So what is targeted agents? Targeted therapies are drugs that target the molecules right on the inside of the cell or on the very surface of the cell. So you can see here that lymphomas have all these little proteins on their cell surface. They're called CDs, or complements of differentiation, and they can be blocked by a lot of different targets. There are also things on the inside of the cell that we can target, and the objective is to kill the cells using a different strategy, slow them down, stop them altogether, and they're far more specific than chemotherapy. So as an example, the monoclonal antibody rituximab, which we heard about, target CD20, which is a surface here. Other ones target a B cell receptor, and then lots of pathways on the inside of the cell here. Polatuzumab and loncastuximab are drug antibody conjugates, which means that they're antibodies that target one of these surfaces, but they also have these little green things next to them, which allows the chemotherapy drug to be delivered almost like hitching a ride with the antibody and getting deposited on the inside of the cell. Other things like the bispecific antibodies bring the lymphoma cell and the immune system cell together for more to augment the anti-tumor immune response, and then CAR T cells. So this is a whole entire category of new and very exciting things that we have available to patients. So I wanted to give you a little bit of a timeline of how immunotherapy came to be. So one of the first immunotherapies that was developed in the 90s is rituximab. So this is the lymphoma cell, the B cell. And the idea is that rituximab targets that CD20 and then allows the cell to undergo what's called complement-dependent cytotoxicity, which brings lots of other molecules together to that region, and then the cell kind of breaks apart. So that's why when you add rituximab to chemotherapy, it makes it much more effective. And someone asked about, can we use rituximab for T-cell lymphomas, angioimmunoblastic, and we can't, unfortunately, because CD20 does not exist on T cells in a way that would make it helpful to use rituximab. But there are other things that are being used for T-cell lymphoma. CAR T-cell therapy, I'll talk a little bit about more, but this is a way where we draw cells from the blood to get a patient's T cells. Those T cells are grown in a laboratory, and we can insert this special, what's called a chimeric antigen, and it's done through a special process where all of a sudden this T cell now gets a new surface marker called a chimeric antigen receptor. It's grown in the dish in the laboratory and then gets put back into the patient, where those CAR T cells are sort of educated, stimulated, and more activated to kill the lymphoma cell. And CAR T cells are now being evaluated and used for many, many forms of lymphoma, as well as leukemias, myelomas, and some solid organ cancers as well. And this came to be in the mid 2010s. And then today we're looking at bispecific antibodies, which, as I mentioned, takes your immune system cell, the cancer cell, and brings it together with this sort of novel antibody that can bring both of them together and kill them. So all of these strategies are being used today. So lots of options, as I mentioned. So going kind of a little bit into the weeds of what are some of the treatments that are being used. So one of the things that you'll hear a lot about is this concept of called R squared. So we talked about how R squared was used together, lenalidomide and rituximab, for patients newly diagnosed with follicular lymphoma. But one of the ways that we first kind of learned about R squared is through this study called Augment, which is what's called a randomized phase 3 study, which is the biggest, most robust scientific type of study that you can do that compares one treatment option with another treatment option. So rituximab was given with lenalidomide for about a year, and then half the patients received this combination, and then half the patients got rituximab with a placebo pill. So they were getting something treatment-wise, but they weren't given the lenalidomide because we wanted to see how lenalidomide compared with placebo. So they received rituximab. And what we learned is that from this study, the combination of the rituximab and lenalidomide, or R squared, worked better than the rituximab and placebo. So for someone with relapsed follicular lymphoma, this became a very appealing choice. Now, not everyone needs the combination. Some patients still can use rituximab again, but this is an important study because you'll probably hear a lot about R squared. R squared is being compared to or added to a lot of bispecific antibodies. And so I think it's important for us to have that as a backbone and understand where R squared came from, and it came from this study. Next, we'll talk a little bit about CAR T cells. So I already described how they work. They're removed from the patient, engineered, expanded or modified, and then infused back into the patient. And there are currently 3 different types of CAR T-cell therapies that are approved for follicular lymphoma. Axi-cel, lysocaptogene or lysocell, and then Tisagen like Lucel or Tisacel. The choice of which CAR T-cell to use depends entirely on the individual person, how quickly we need the CAR T-cells for the patient, what some of the toxicity profile is, what are the side effects. So that's a conversation with you and your doctor to decide if this is the right choice for you. But CAR T-cell therapy is only approved in the United States for someone who's on their 3rd treatment. So you really can't get CAR T-cells if you had, let's say, rituximab first, and then your lymphoma has come back a couple of years later. We would not be able to provide this because it's approved for the 3rd, when you're on your 3rd treatment. If someone has transformed lymphoma, it's a little different. You can probably get it as a 2nd treatment, but you have to sort of see whether you meet that criteria, and your doctor can explain that to you in better detail. So this is like a bird's eye view of some of the different results that we see with the different CAR T cells in follicular lymphoma. These are the titles of the different studies that have used them. And as I mentioned, these are the prior, what we call lines or rounds of therapy. So here, Everyone had at least 2 prior lines because that's what the FDA said, that you can only get it as your third round of treatment. The number of patients in each trial was about 100, 120 patients. And you can see that a very, very high response rate, almost 90% or above in terms of response rate, which is extremely promising. And then we look at a lot of other things here. So we look at something called progression-free survival, which tells us how long is someone alive without having recurrence of their lymphoma or being progression-free. So at last follow-up, this tells us that for this first one, Axicell, which was the first one to be approved, the average progression-free survival was 40 months. So on average, after 40 months, patients were still, the majority were still alive and progression-free. For patients that achieve that, it was at least 3 years and counting in terms of average, how long it lasted, or what we call duration of response. And then you can see sort of the same thing for these other ones. These two columns, the last ones, refer to some of the side effects that we see with these treatments. One of them is called CRS, or cytokine release syndrome, which is like a massive inflammation response that the body can have with CAR T cells. It's when you have like a flu-like illness, but very, very severe. High fever, shaking chills, needing a workup for infection, IV fluids, antibiotics, sometimes steroids, sometimes something stronger, to bring down all that inflammation, because your body is experiencing this massive inflammation cascade, which is something that we kind of know, anticipate, expect, and know how to treat very, very well. But that could be a very severe side effect, and it can be life-threatening. So we must go into it knowing what we're up against. And this tells you the rates of CRS, or cytokine release syndrome, overall, and the very severe forms of cytokine release syndrome are in the parentheses here. So fortunately, severe cytokine release is not common. And then this other toxicity called ICANS, or it's another word for it is neurotoxicity. And neurotoxicity is when people can experience confusion, lethargy, changes in their mental state. And that can be also a very serious side effect of CAR T cells. But again, this is very well established. We know how to treat these, and to some extent, we know how to predict them too. So we're leaps and bounds in terms of knowing how to address some of these side effects. So other treatments that are in the pipeline, as I mentioned already, are the bispecific antibodies. So really capitalizing on the immune system to help fight your disease. So again, as I mentioned, the T cells, which are part of our immune system that recognize viruses, parasites, cancers, they're meant to be activated. And when they're activated, then they can recognize bad things going on in the body. And the idea is that when you pair it to the lymphoma cell by targeting CD20, you can bring that together and have a better anti-tumor immune response. So currently there are 2 bispecific antibodies that we can use for follicular lymphoma. There are many others that are in development and approved for other diseases, but I'll just focus on these 2 for now. One of them is called mosunetuzumab, which we heard about. A very exciting drug that can be given either by vein, so I intravenously, or subcutaneous, meaning it goes like as a little injection under your skin for about 10 minutes or less. And then we always give people tiny little doses at a time, so what we call step-up dosing. And we ramp up the dose, several dose levels, until we can get to that maximum dose for safety, and making sure that your body can handle getting that. And then the way that mosunetuzumab was developed is as a time-limited therapy, so people get it for around a year, and it's being combined with many other things like we talked about. The other one is called epcoritamab. It was developed primarily as a subcutaneous injection. There's also step-up dosing, but this one has indefinite treatment for follicular lymphoma. There are newer studies that are looking at it as a time-limited therapy and combined with other things, but at least for right now, if you use it by itself, it's indefinite treatment. Both of these drugs have a very high success rate, over 80%, very promising. Also for the third round of treatment, so what we call third-line therapy or later, for follicular lymphoma. So shifting gears to what other targeted therapies. So there's a whole class of therapy called BTK inhibitors, or blockers of this pathway called Bruton's tyrosine kinase. So Bruton's tyrosine kinase is what we call an intracellular enzyme. That means that it's found within the cell. This is the cell membrane, so you have to bypass the cell surface to get on the inside of it. So these are drugs that are given by mouth, oral medicines. There are lots of them out there. zanubrutinib, acalabrutinib, ibrutinib, that are approved for different forms of lymphoma. And in follicular lymphoma, zanubrutinib has been shown to be quite promising. So zanubrutinib was studied in combination with a medicine called obinutuzumab, which is like another version of rituximab. There were about 200 patients or so that were included. And then patients were given either zanubrutinib combined with the obinutuzumab, so the IV in the pill form, or the obinutuzumab, the IV form by itself. And they discovered that it was the more successful when you gave the combination of zanubrutinib and obinutuzumab compared to just the obinutuzumab by itself. And the average estimated response duration was about 18 months. When they measured it at 18 months was about 70% in the zanubrutinib and obinutuzumab arm. So this is another nice option for patients, depending again after a discussion with your oncologist whether this is appropriate for you, but this is another approved treatment strategy for follicular lymphoma. The other one is a drug called tazemetostat, which is a drug that blocks another intracellular enzyme it's a gene, called EZH2. EZH2 is something that our bodies depend upon to make lymphoid follicles, or the inside parts of our lymph nodes. And if EZH2 is mutated in some way, it makes that pathway of lymphoma growth, it kind of changes it. And so patients that have EZH2 mutated in their lymphoma are eligible to receive this drug. Even if their lymphoma does not have the EZH2 mutation, you could be eligible for it. The success seems to be a little bit higher if patients have the mutation. However, it's still a very well-tolerated drug, and the length of success of treatment is very good, whether someone has the mutation or they don't. This is one of those drugs that's also taken indefinitely, like zanubrutinib as well, and it's being combined with other medicines to see if it works better or gives a longer treatment response. Tafasitamab is probably one of the newer kids on the block in follicular lymphoma. Lots of interest on this drug recently. It's an intravenous medicine that targets CD19, which is another of those surface markers. And the idea is that when you use tafasitamab, that it induces a lot of other things in the cell. It induces your immune system to come and figure out kind of like, hey, what's going on? I see that CD19 is being targeted. It also causes the lymphoma cells to die directly, called direct cell death, and then also cause other things within the immune system come and kind of clear that lymphoma from the system. So tafasitamab is being combined with many other approaches, but in particular, it's being combined with R-squared, and that was based on a big international study that was recently presented that compared tafasitamab R-squared against R-squared, and tafasitamab R-squared seemed to be more effective. However, we're still getting more mature data to see, but thus far it appears that the study demonstrated that the tafasitamab with R-squared was a more effective combination compared to the R-squared by itself. So just to kind of put things in context, kind of where we are. So there are many ways of thinking about follicular lymphoma treatment at the time of relapse. And the way that, we tend to think about it, or at least I do, is thinking about what we call that second line treatment, or that next treatment after you've been treated once before, and then third line treatment. So second line treatment, at least I think about it in terms of, is this patient having an early relapse within 24 months? Or are they having a late relapse? Or are they needing third line treatment? So we always, whenever possible, encourage participating in clinical trials, because clinical trials can offer people the hope of a treatment that otherwise would be inaccessible to them. So if you have a clinical trial available to you, I would encourage you to speak with your doctor about that. And what we think is that for someone that has early relapse, a clinical trial is really the best option, because we have data that suggests that those patients don't do as well compared to those who may have had a much later relapse. Things outside of a clinical trial are squared, lenalidomide with that obinutuzumab antibody, tafasitamab with R-squared, or a bispecific antibody with lenalidomide if that's accessible. It's not always accessible. Chemoimmunotherapy too could be used if none of these other things are available. And then we didn't really go into transplant. That's a bit of a bigger topic, but transplant either from someone's own body, called an autologous transplant, or an allogeneic transplant, which is a transplant from a donor, are probably used less frequently in follicular lymphoma, given that we have so many other options available. For someone whose lymphoma has relapsed later, similar options as well, but chemoimmunotherapy is probably another good option as well. I think less the case for this, but certainly possible. And then for third line, we talked about bispecific antibodies, mosunetuzumab, epcoritamab. There's one called odronextamab that's approved in Europe, CAR T cell therapy, and then all these other combinations that we spoke about. So lots of really, really good and effective options, fortunately. So just to conclude, I also want to end on a high note of hope. Lots and lots of treatment options, extremely efficacious, successful treatment options. Not everybody needs to be treated when their lymphoma comes back. We have a lot of emerging treatments that are being combined or used by themselves, and lots of hope for patients. So I'm really excited to be on this journey with patients because I get a lot of benefit of seeing people get better and staying better for a long time. So that's about all I have. So thanks again for the invitation, and I will stop sharing.
Thank you so much, Dr. Casulo. We're going to get into some questions now. We do have many questions in the Q&A, so I was going through them, just trying to combine them where I could. So I will hopefully be able to address everyone's concerns today, or at least something in that same bucket. But if anyone does have leftover questions after today, you can always reach out to our helpline. And I just sent that information in the chat, but I'll talk a little bit more about that before we wrap up today. But our first question, I'm going to direct to Dr. Armand. We had a few questions about active surveillance, and participants want to know what protocol you follow for patients on active surveillance or watch and wait, and how often would you have someone come in for scans and blood work?
That's a great question. It's a hard question because I think all of us do things a little bit differently. So I'll tell you what I do because that's what you're asking, but that doesn't mean it's the right thing to do. And I think a lot of it is informed by people's tolerance for uncertainty and for risks. So I basically do no scans. And the reason for that is because I don't treat follicular lymphoma based on the size of the disease. I treat really based on people not feeling well. It doesn't matter to me whether a node is 6 or 8 centimeter, whether you have 3 nodes that are 3 centimeter or 2. If you're well, I think it's fine to continue watchful waiting. Because of that, I don't do scans because the fact that it's enlarging wouldn't change my approach. And the reason for that is that when you do a scan, you're exposed to radiation. And the way we do scans with like chest, abdomen, pelvic CT, it's not a negligible amount of radiation. So, and radiation has harm. It increases the risk of second cancer. It's a very, very low risk. But for me, my approach is if you don't really need a scan, don't do one. There are people very prominent lymphoma doctors, real experts who treat based on burden of disease. And they feel like, okay, when the burden of disease is high enough, let's treat before patients have problems. And that's a reasonable approach. That does require a little bit more imaging because it's hard to know the size of something if you can't feel it. But for me, because of what I just mentioned, I basically don't do scans unless there's a problem or unless the patient requests it.
Thank you, Dr. Armand. And Dr. Casulo, to start us off, can you review what symptoms might indicate that someone's follicular lymphoma has relapsed?
Sure. So I find that it's often some of the things that led them to be diagnosed. So if they were diagnosed with a new symptom or a lymph node in an area of the body that's superficial enough that you can feel it, then that's often what could happen. So what we call palpable or a feelable lymph node. But sometimes people are diagnosed by accident that during a colonoscopy or if they have a mammogram or something like that and they're diagnosed that way. And so typically you wouldn't really pick it up again unless they're doing those routine surveillance strategies. But in general, the things that we often attribute to lymphoma are things like fatigue that interferes with your ability to do things that wasn't there before. So like a shift in your normal day-to-day, or having night sweats, or having a change in your blood work, or having new or different pain, or something that just doesn't feel normal to you. And I really encourage patients to trust their bodies and trust if something doesn't seem right to them and have that looked into further. But I too don't scan that routinely for the same reasons. So occasionally, if someone asks, we do, and in certain contexts I do. But if someone's been well for 5 years, I don't do, scans yearly because it doesn't actually pick up anything actionable, and then sometimes picks up incidental things that you end up pursuing that put somebody through an unnecessary biopsy or an unnecessary procedure.
Thank you. And Dr. Rahman, we got a few questions about staging. Can you review the stages of follicular lymphoma, and can you review what is categorized as early versus advanced stage?
Thank you for asking. So the first thing is what we use to stage patients these days is typically a PET scan. In the US, that's the standard baseline test, which is, it says almost a head to toe. It's not quite head to toe. It's the skull base to the thighs typically, but it's a scan that's very sensitive at picking up follicular lymphoma. The other place that people used to look more is the bone marrow by doing a bone marrow biopsy, but I think many people have stepped away from doing routine bone marrow biopsies, at least outside of clinical trials. So on a PET scan, what we look for is disease. If it's just in one area, for example, if it's in the left neck and that's it, then we call that stage 1. If it's in more than one area, but all on the same side of the diaphragm, for example, left neck and right armpit, we would call that stage 2. If it crosses the diaphragm, for example, left neck and right groin, we call that stage 3. And if it's outside of lymph node, for example, the bone marrow or in the liver, in the lungs, and then we call it stage 4.
Thank you. And as a follow-up to that, Dr. Rahman, do you only consider radiation treatment for stage 1, or would you consider it for someone who is at stage 2?
Oh, great question. And actually, I know you asked me the question with the first time. But so early stage is stage 1 and 2. In theory, you can use radiation for both. We know that the outcomes, not surprisingly, are better if you radiate stage 1 than stage 2. So I said you can expect cure in about 50%. It's probably about 40 to 50% for stage 1. Stage 2, maybe 30%. But it's a little different if like stage 2, but in the same area versus stage 2 far apart. It's probably different. Nobody's shown that. I'm making this up, but it sort of makes sense. The more disease you have, the less likely radiation to work. Just like if it's more bulky, radiation is less likely to work. Even if it's stage 1, if it's more than 5-6 centimeter, it's less likely to work. Basically, the more disease, the less likely it is to work, but you can consider it under certain circumstances.
Thank you. And Dr. Casulo, we have a few questions about kind of the research landscape for follicular lymphoma. So first, do you find that funding for follicular lymphoma research lags behind other subtypes since it is considered indolent?
No, I don't actually. I think that there's a lot of research being done in follicular lymphoma and quite a few funding mechanisms to get someone's research come to fruition, their ideas come to fruition. I mentioned some of mine. The Lymphoma Research Foundation is currently funding one of my projects that I, in collaboration with researchers at Mayo Clinic. So it's not, I think, unfortunately, the funding, what we call the funding landscape or the available, the money that's available for people to do research has changed in the last few years and there's more competition for people that want to study things, but not just because follicular lymphoma is indolent. It's the second most common disease, in the second most common lymphoma worldwide. Thousands of patients are living with follicular lymphoma, and I think there's a lot of interest in understanding the biology and treatment for follicular. So I think there's a lot going on in research for it.
And as a follow-up to that, is there any interest from the research community in studying how lifestyle changes might impact follicular progression or prognosis?
Yes, there are some. There's definitely an interest in understanding the patient's perspective on what's important. What are some of the important questions that we should be asking in follicular lymphoma? To my knowledge, there aren't any that I'm aware of currently that are studying lifestyle interventions, but one of the things that we're looking at is studying patient opinions on what's important in terms of treatment strategies and treatment sequences and side effect profiles. But there's a lot of research that's being done in oncology overall to understand exercise and dietary approaches and how that impacts your survival. So from an oncology standpoint, there's a lot of activity and research going on there. In lymphoma specifically, I'm not familiar with any that are looking at those questions. I don't know, Dr. Armand, if you're familiar with active research studies targeting the lifestyle question.
Not that I know of either.
That's okay. Thank you both for the insight. Regardless, and of course, if this person has any follow-up questions or wants us to look into anything for them, they can certainly reach out to the helpline. Dr. Armand, we had a question here that I think is important to address. So, since lymphoma might retain behaviors or healthy lymphocytes, is there any risk in getting vaccinated, or anything that shows that vaccination might somehow promote lymphoma growth?
Great question. So I'd say, if I may, I'll give you different levels of answer. The textbook answer is not only is there no concern, but it's the opposite. Patients with follicular lymphoma should be vaccinated because follicular lymphoma impairs the immune system a little bit, so they're more likely to get sick. That's particularly true if they start treatment, because rituximab, which is part of every treatment almost, as we talked about, not only makes people more likely to get sick if they catch viruses, even like COVID, but also it impairs ability to respond to vaccine. So if you start Rituxan, you're not going to respond to vaccine for probably at least a year until the end of that Rituxan treatment. So I strongly encourage my patients to get all the possible vaccines, certainly before they start treatment, and ideally as early as possible for those reasons. Now, the next level is there are a lot of things that we don't understand well. And follicular lymphoma is an immune-sensitive disease. There's a very strong interplay, I think, between the immune system and follicular lymphoma, which is why I think some people don't progress, or we see spontaneous remission sometimes. And so when you vaccinate someone, you do affect their immune response, and that could go both ways in theory. So there are patients who feel like their nodes have increased, for example, after COVID, that don't come back down. Vice versa, there are patients who get vaccines and then go into remission. So I think it would be a little bit, it would be imprudent of me to say that vaccines can affect it, but because we don't know of a detrimental effect and we don't really understand it well enough to know for an individual patient, my strong recommendation is vaccinate everyone as much as you can.
Thank you, Dr. Armand. And actually going to ask you another question here because we did receive a few
Wait, it's
about.
Carla's turn. Just kidding.
It's not always one-to-one here, but so we did receive a lot of questions on the impact of treatment on the immune system. And I'm going to use one of the questions here as an example that I think touches on a few points. So my wife was treated with chemo and radiation in 2021. The treatment helped her tumors, but hurt her immune system. She takes Gamma Guard every month to build her immunity. Does this ever change, or will this ever change where her cells regenerate and she would not need infusions every month, or is this the new normal?
So it's a hard question. And obviously, as you know, and as we mentioned earlier, we can't give individual advice because it may be totally inappropriate for your wife. So I just say in general, the treatments like the ones that your wife received can cause prolonged problems with the immune system or with antibody formation. And some people are on IVIG. Sometimes they can come off, sometimes they don't. And so it's impossible to say for sure, but certainly if the question is it possible to come off, the answer is yes. These problems can get better. They don't always.
Thank you for speaking to that more generally. It's much appreciated. Now, Dr. Casulo, we do have a question for you. How do you know if your follicular lymphoma has transformed to an aggressive type of lymphoma? And if it does transform, how concerned should you be about your follicular lymphoma returning following treatment for the aggressive type of lymphoma?
So some of the symptoms that I alluded to earlier can be symptoms of diffuse large B-cell lymphoma as well. Occasionally, there could be a situation where the behavior of the lymphoma is not in keeping with what you'd expect for follicular lymphoma. So for example, you see someone in January, and then you schedule a 6-month follow-up, and then 3 months they're calling with, very rapid lymph node growth, feeling really poorly, and then maybe blood work showing some concerning changes. So typically large cell lymphoma, it grows faster, and so it has symptoms that are more noticeable. There are things that you can pick up on blood work and on a physical exam. And then usually that would lead to some form of testing, sometimes CAT scan, a biopsy, PET scan, etc. And then the way you diagnose it is through a biopsy. So it is a serious situation to have your lymphoma become diffuse large B-cell lymphoma, because the treatment has to be different at that point. And it also has implications on a lot of other things, like surveillance for recurrence of follicular lymphoma, for example. I think that sometimes you can have recurrence of follicular lymphoma even after you've had treatment for transformation. There's some mixed data on kind of what the percentage is of follicular lymphoma relapses versus diffuse large B-cell lymphoma relapses, but both possibilities are still there. So we would have to be vigilant for both possibilities, moving forward. I hope that was, I think I may have said things that you didn't ask me, but hopefully it covered.
No, I think it was great. Thank you so much
It's
for
better
your
than me
insight on
not
that.
answering part of the question.
Dr. Armand, next question here is, does patient age at diagnosis impact treatment considerations?
Yes, to some extent. Obviously, it depends where you're asking about. People have to be able to tolerate certain intensity of therapy when you're considering more intensive therapies. Fortunately, most of the treatments for follicular lymphoma, both for frontline that we talked about and for relapse disease that Dr. Casulo so well summarized, most of those treatments can be delivered quite late. Even treatments like CAR T-cell, which is a pretty intensive treatment, I think many centers are treating people in their 80s. So yes, if you're 99, okay, that's going to limit a number of treatments, but in general, most treatments are tolerable for even, let's say, older people.
Thank you so much. And I think this will be our final question for today for you, Dr. Casulo. Um, and it's probably quite a loaded question, but what is the side effect profile for bispecific antibodies, and how does it compare with the side effects of CAR T-cell therapy?
Yeah, they're actually somewhat similar, but the degree to which they occur is slightly different. So side effects of bispecifics include the possibility of cytokine release, a much lower possibility of that neurotoxicity that I mentioned, the confusion, the um, change in mental state, the level of alertness, things like that. And also the severity of that is much, much lower with bispecific. In fact, almost never seen with bispecific antibodies. Um, there's also potentially the pain at the site of the injection, depending on if they get it as a subcutaneous injection, which we're doing more and more. So that can sometimes yield a reaction on your skin, and sometimes that can spread to other parts of the body that haven't had the injection, and you could have more of a itchy, more uncomfortable, like scaly rash. Sometimes it can cause other sort of like off-target effects, like headache or nausea or blood count changes. Sometimes you can have a flare reaction too, where the lymph nodes, they suddenly get bigger, even though there doesn't seem to be progression of the disease, but it can stimulate like a flare, like an immune response. So those things can happen as well. But CAR T-cell therapy is a completely different approach. I think of CAR T-cell therapy as a treatment program because it involves multiple different steps. It takes far more time, I think, in terms of the coordination, and there's other considerations. You need a caregiver, you need to live a certain distance from the cancer center. You need to get what's called lymphodepleting chemotherapy, which is chemotherapy that you get right before you get your CAR T cells in order to create space for the new ones to get in there. And so it's very different, I think, but the scope is different. But I think that the severity of the CAR T cells are different. But some of the two primary ones, the cytokine release syndrome and the neurotoxicity, are the ones that overlap. And then there are late effects with CAR T cell therapy, like the low gamma globulins that the patient asked about. You can have prolonged what we call hypogammaglobulinemia for several months, if not longer, with CAR T cell therapy. You can also have low blood counts and an impaired immune system for quite a long time after CAR T cell therapy. So those are kind of like those are the most important side effects, I think, worth mentioning.
Thank you so much, Dr. Casulo and Dr. Armand, for answering our questions today. Before we wrap up, I also want to thank each of our attendees for joining us. Please remember, if you have any additional questions or if you'd like to be connected with someone else who has been impacted by lymphoma, you can reach out to the helpline. The number is 800-500-9976, and their email is helpline@lymphoma.org. I also just sent in the chat the link to register for Living with Lymphoma if you want to attend the follicular lymphoma breakout session and kind of continue the conversation from today. But with that, thank you so much again to Dr. Casulo and Dr. Armand for your time today.
Thank you so much for the invitation. It was great.
Thank you. Thank you.
Take care. Bye-bye.
Have a great rest of your day.
You too.
Bye.